Simran, you there?
Yes, ma'am.
You there क्या? क्या कुछ हो रहा है कि what is it?
Sir is trying, ma'am. There is some issue, I guess.
Okay. Okay.
Ma'am?
Yes.
We'll start again because there was some technical issue, I guess.
Technical glitch, I guess.
Yeah. So, hello everyone. Just 1 second. Hello. Yeah, we'll start from the beginning, ma'am. So, hello everyone. I'm Dr. Simran Agrawal, and I would like to welcome you all to the grand new webinar which is conducted by the Mediash. As the representative of the Mediush, it gives me great pleasure to introduce our organization to you. So, Mediush is organization which runs by the doctor for the doctor. We conduct various webinars, events, workshops, quizzes, and vlogs to spread the knowledge and awareness regarding dentistry, especially among budding dentists. Many of you have attended our last webinar, which was conducted by Dr. Vignesh, an endodontist, where he guided us on NEET PG preparation. And today we are here with another webinar on equally important topic. There is common myth among general practitioner and BDS professional that periodontics is just about scaling. However, to burst this myth bubble, we have with us our talented and extraordinary person, Dr. Lynette Fernandes. She completed her undergraduate degree from MGM Dental College, Mumbai, and pursued her MDS in periodontics from GDC Mumbai. Currently, she works as an assistant professor at GDC Mumbai. Dr. Fernandes has came up with a very interesting topic for today's webinar. That is periodontics for general practitioner. I request ma'am to take the lead and start with the webinar. Also, whoever has any question can put up in the chat box so that we can discuss it later.
Thank you, Simran, for your kind words. So we'll begin.
Yes, ma'am.
Is my screen shared?
Yes, ma'am. It's visible.
Okay. So, a very good afternoon to everyone. A very good afternoon to everyone who's present here today. Our topic for today is periodontics for the general practitioners. Okay. So, when a patient comes to you in the general practice, what you have to do is learn to diagnose the case. You cannot just say if there's mobility, we're going to extract the teeth. You need to learn to diagnose what has caused the mobility and what are you going to do as a treatment for it. So that is what we are going to learn today about knowing how to diagnose a case and its treatment, how to formulate a treatment plan so that we can salvage the tooth rather than go for an extraction or any other treatment procedure. So supposedly this patient comes to you. You need to identify. And we as periodontists know gingiva the best. So we'll begin with knowing the gingiva. As you can see, this margins. So this is your marginal gingiva. This portion interdentally is your interdental papilla. This portion from the base of your pocket or your sulcus to this line which you can see. This line which changes color beneath. This is pink, pale pink, and this is reddish. So this line is known as the mucogingival junction. And beneath this portion is going to be your alveolar mucosa. Your alveolar mucosa is loosely attached. It is movable as compared to this attached gingiva. So you can see in this case, this points. So this is known as stippling. So when you see stippling, you know that your gingiva is healthy. This is a case of a healthy, proper gingiva. If this is going to be, and it's nice, pale pink. If it's going to be a bit reddish, you could say that the signs of inflammation, as we know the signs of inflammation, rubor, calor, dolor. So your redness is going to be a sign of inflammation. Inflammation of the gingiva is going to be gingivitis. So we'll learn what is gingivitis versus periodontitis. So in your gingivitis, it's going to be your red gums, your swollen gums.
Sorry to stop you, ma'am, but the slide is not moving. Like we are just on the first slide.
It's not visible?
It's visible, but we are not shifting to another slide. Yeah, now it is.
So did you see the slide?
Yeah, we can see the second number slide is visible.
Yeah. So knowing the gingiva, we saw the marks, right? Marginal gingiva, interdental, you're attached, your mucogingival junction, which is this line, changing it. And this is going to be your redness, which is going to be your alveolar mucosa, your movable. Since you all could not see the slide, I'll just tell it to you again in brief. Marginal, attached mucogingival junction, movable gingiva. This is your stippled gingiva. This is stippling. Stippling is this orange peel-like appearance which you all can see is basically a sign of a healthy gingiva. When this goes away, you can see signs of gingivitis, inflammation of gingiva. Okay? Going ahead, what is gingivitis versus to periodontitis? So, is gingivitis and periodontitis are not two different entities. It's basically your gingivitis which is going to progress into your periodontitis. So, this is gingivitis where it is your red swollen gums, your bleeding gums. When it's red, it's going to bleed. And when it progresses further on, it gets converted to periodontitis. As you can see here, this is your marginal gingiva which we saw. It's so bright red right now compared to this upper pale pink portion. So this is gingivitis, bleeding gums, red gums. But when this gingivitis goes further ahead because of something which is known as your calculus, your plaque, which further mineralizes to form calculus. So when this calculus keeps going beneath, it's going to cause a loss of attachment. As you can see, your gingiva has lost its attachment from the tooth. So this is going to be your Can you see the slide?
Yes, ma'am. We are on the third slide.
Okay. So this is going to cause a loss of attachment and so-called recession. And this recession, loss of bone, going to be loss of bone. Seeing this in your patient's mouth, when you see, this is going to be your gingivitis. When the patient comes to you, you can see redness of gingiva. You will say gingivitis. When it goes further, you can see that there is loss. Your gingiva has come beneath your CEJ. What is recession? When your gingiva goes beneath your cemento-enamel junction. So when it goes beneath your cemento-enamel junction, it's going to be known as recession. So this, when you see this signs of recession, of redness, of bleeding, that is going to be your periodontitis. What is the cause of all this? The cause of all this is basically your plaque, your calculus, that is the causative agent. Like supragingival plaque and calculus definitely contributes to it, but further on, something which is more dangerous, which is going to cause all this periodontitis, is going to be your subgingival calculus. So you can see this calculus which is present beneath the gingiva is your subgingival calculus. So you need to identify this subgingival calculus in your patients. You cannot just do a supragingival scaling and let it go. If you can see, there will be a slight bluish hue to your gingiva or blackish hue to the gingiva. So you should identify, you should know that these areas could harbor the subgingival calculus. And definitely if you leave it like that, you're going to have this condition what is going to occur, which is going to be your loss of attachment. Your gingiva is no more going to be stuck to your bone or your tooth. It's going to be coming off. Loss of attachment. So this is where periodontists play a role. We saw what is your subgingival calculus and all this, but basically how does periodontitis caused? It's because of this model of pathogenesis, your classical model, which is your microbial challenge, that is in your plaque. There are going to be microorganisms. That microorganisms are going to secrete some compounds, going to act on us. It's going to cause immune modulatory changes. This all concept is going to cause, of course, connective tissue and bone loss. If there's bone loss, iska matlab it is periodontitis. Along with that, we're going to have environmental factors and genetic factors which are going to further enhance the condition. So in general practice, when a patient comes to you to place a crown, you're not just going to go directly and get the crown placed. You have to see if that tooth which you're going to place a crown on, is it mobile? Is it free of calculus? Is it proper? If not, you cannot just go ahead and place a crown without knowing the periodontal condition. Because if you don't control the periodontal condition of that tooth, the other treatments are going to ultimately fail. Your crown or your entire tooth is going to come off if you're going to place a crown on a periodontally compromised tooth. if there's this bone loss, if there is calculus, and you just place a crown and let it go, it's not going to work out. So periodontal treatment is a challenge, but we are up for it, right? Basic case history of every patient whenever you come, we've learned it from our BDS days. You need to know medical history, dental history. Coming to the most important things is going to do oral examination. When you do oral examination, after oral examination, you're going to have to do a radiographic examination as well. Are the slides moving or not?
No, ma'am, that's what I'm asking. The presentation has been stopped. We are still on the slide 3.
Oh, is it?
Yeah. And can you make it full screen like?
It is full screen यहाँ पे मेरे इसमें.
No. मतलब the side का is visible ना, तो make it full screen.
Yeah, मेरे इसमें it's actually full screen. 1 second. I'll just start presenting again. Visible?
Yeah. Slide number 6, I guess.
Moving?
Yes. We are on slide number 6 right now.
Okay. So you all saw this slide, or I don't know if you all did. So this was the subgingival calculus. If the slide was stuck, I'll just show it to you all. This is the subgingival calculus, as we said. It is going to be present beneath the gingiva. This is the tartar. You're going to see a bluish hue which is present. So you should know that there is something present. And just not leave it after judging the supragingival. Yeah, you can just check it out. Your subgingival, beneath the gingiva. And if that progresses, it's going to cause your loss of attachment, as you can see in this picture. And I had shown this model of pathogenesis, which was basically your microbial challenge on your host, leading to your destruction. And our challenge. So we identify, we go ahead and do the periodontal examination. So for the periodontal examination, what we check is going to be your signs of inflammation, your etiological factors, your signs of inflammation, which is going to be your redness, your swelling, your bleeding on probing. Your etiological factors, that is the causative factors, your plaque, your calculus. And you're going to see your probing depths, your sulcus depth. I think you'll know what is the sulcus. Your marginal gingiva के यहाँ पे sulcus था. When?
Ma'am, still not moving presentation.
Why is it happening?
You can change it manually, otherwise if it is not.
I'm changing it manually.
But we are still on the slide 6.
It's gone ahead now?
No. Yeah, right now we are at 8.
Now? Changing?
Still at slide 8.
I think there's some lag, I guess. Because I'm
Maybe.
on 8, 9, 10. Moving or not?
We are on slide 7. Like I can see slide 7 right now.
I'm on 10. सिमरन
Yes, ma'am.
हो रहा है?
Yeah, we are at 10 now.
अभी is it moving or not? Like my pain is there.
Yes, we are at 10 now. If you just move so I can see.
I think lag हो रहा है बहुत ज़्यादा. Changing?
Yes, yes.
हो रहा है ना?
हो रहा है मैम अभी.
अभी हो रहा है? अभी हो रहा है?
हो रहा है मैम. Yes, yes.
I'm on drug-induced gingival enlargement. Is it visible?
Yeah, it is.
Okay, just let me know when it stops again.
Yes, ma'am. No issue. You can continue. Yes.
So, I think we were at this. Yeah. So the case history, as we said, case history, clinical examination, after clinical examination, a radiographic examination. So in the clinical examination, we'll see for signs of inflammation. We'll see for the causative factors. As we saw, the causative factors are going to be a microbial challenge that is present in your plaque. So that are the causative factors, your plaque, your calculus. And then we are going to see your probing depths and your clinical attachment loss values, which I will show you all further. How do you measure your probing depths? Along with all this, what we have to see in every case, what we see is going to be your keratinized gingiva, your mucogingival junction, and other things like furcation, mobility, bone levels. All these things have also to be seen. So, is it changing a bit, the slide? Simran?
Yes, ma'am, it is.
How to probe? Okay, so we're going to learn how to probe. When we, as periodontists, we use this, which is known as a periodontal probe, a UNC 15 probe. We call it UNC 15 because there are 15 lines on this, the 15 markings to help us gauge the periodontal pocket. If not, if you all cannot use this probe, you all can use a Williams probe. But that normal probe, which has no graduated markings on it, is of no use. So first thing first, we need to have a probe if we want to know the periodontal condition of the patient. It's a must. So this is a Williams probe, if not a periodontal probe, a Williams probe which has markings of 1, 2, 3, 4 and 6 are missing. We have 7, 8, 9, 10. So it gives you marking up to 10 mm. That is the Williams probe. So when we are probing, we do not keep removing the probe out. We go and we walk the probe along the entire gingival sulcus. We keep walking the probe throughout until we record all the pocket depths. And this is how we go. It's going to be parallel like this. It's going to be parallel along the tooth structure, never angulated like this. It has to go along the tooth like this, along the tooth surface, not following the contour like this. It has to go nicely along the tooth surface. You're going to feel the entire root portion. That's how you're going to probe. Yeah. But coming to this area, जब वहाँ पे the two teeth are stuck, contact points के यहाँ पे you cannot go straight. So if you want to probe this area beneath the contact point, you need to know if there is a defect here. So when you want to probe this area beneath the contact point, we are going to...
Sorry ma'am, slide is still stuck on 13th.
I really don't know. What is it? On 13th?
One of our YouTube members is saying like just press F5 if it is possible.
F5 is dictation on this. I'm trying to make it into this in my screen. It is coming as a full screen thing. I really don't know how it's not visible elsewhere like that.
Which slide you were exactly right now?
The probing slide, 9th slide.
Yeah, 9th, correct. We are at 9th.
Yeah, but it keeps changing. Any changes? What's happening?
We are at 9th, ma'am.
Not gone to the 10th slide?
No.
अभी हो रहा है change?
No, we are right now we are at 10th. Yes.
I'm on 15.
10th one is. Yeah, 15, correct. Now it's changing.
So I think यहाँ बाहर से ये change हो रहा है. When I'm doing slideshow, it's not changing.
Maybe.
Yeah, that's... Okay. Is it visible like this? If I go ahead like this, if it's okay?
Yeah, no issue.
Okay. So this is what we were talking about, angulation of the probe. You all could see the slide earlier.
This 7, huh? Right? Okay, let's read.
Okay, so this is the angulation of the probe, which we need to keep it straight, parallel, along the tooth surface, not away from the tooth surface. Okay, this is how we are supposed to angulate. Beneath the contact point, since this area will not be probed, we have to tilt the probe slightly, but this again along the tooth surface. You're not supposed to go and probe it interdentally. Contact point के यहाँ पे through and through नहीं जाना है अपने को. We are supposed to go along the tooth surface and go interdentally. Okay, not just through and through the contact point. Okay. Now coming to how will you see a periodontitis case in a patient? Now suppose this patient comes to you in your practice. So what you see यहाँ पे is going to be all these things. You can see suppuration, right? Pus discharge दिख रहा है. There's suppuration, there's diastema, there's gap. That's because of your loss of periodontal support. You can see these signs of your recession. यहाँ पे recession beneath the CJ is known as recession. Your inflammation, your redness which is present over here, this is your inflammation. So looking at all these signs, we know that this case is going to be a periodontal case. But to make yourself sure, you have to take a probe and check for pockets. You start doing that. Along with that, you have to take a radiograph to know how much is the bone levels in your case. So this is the radiograph of this very same case. We take an OPG because the entire area looks inflamed. Take an OPG. But you know in an OPG, you're not going to be able to see properly your anteriors, or certain areas are not going to be properly visible. So your final thing is going to be of the affected areas, always take an IOPA. So we have taken an IOPA of the affected areas. As you could see in this previous thing, the suppuration. So you know this is an area of concern. So when you see this area in this, you can see radiolucency, that is bone loss. So this was an area of concern. You can see in this area, there's so much amount of bone loss which is present, as well as in this area, this area. So this is a case of generalized periodontitis. All these areas where there is so much amount of bone loss. When you see this in an IOPA, you realize that this thing has got infected apically also. Hence, you check for vitality of the tooth, do a root canal treatment, and then progress ahead and do whatever treatment plan which will be indicated in this case. You'll see that ahead. So this is just how you diagnose a case. You see the case, take an OPG, take IOPAs, start probing, and come to a diagnosis. Go ahead and formulate a treatment plan. Now, whenever we take IOPAs, many a times you'll all feel that this is bone loss. But no, bone loss is only when you know your CJ, right? So, when the distance from your CJ to your bone level is more than 2 millimeter. So, this is a proper case. There's no bone loss in this. You cannot say your bone is never up till your contact point. It's always 2 millimeter below from your CJ. So from the CJ to your bone level, if it's 2 millimeter, this is a normal radiograph. When it is this condition and this condition, this is known as alveolar bone loss. Now there's something which is horizontal and vertical alveolar bone loss. When you see this CJ, if this CJ of this two, this is a maxillary teeth. The CJ is here and something which is parallel. Your bone loss is parallel to your CJ. That's going to be your horizontal bone loss, right? Horizontal lines ki tarah. Whereas your vertical bone loss or your angular bone loss is not parallel to your adjacent CJ. This is like this. This is your angular bone loss. So we've come to know when we see a patient how to realize gingivitis case, periodontitis case. Take an OPG. When there is bone loss, matlab periodontitis tak progress ho gaya hai. We check for the IOPAs. You come to know in the IOPA whether it is a horizontal or a vertical bone loss. When it's your vertical bone loss, there's something which is known as a periodontal bone defect. We'll check this out ahead also. This is a bone defect. And this is a periodontal probe, which we saw earlier, used to diagnose the depths of the bone. So we saw bone defects. Now we'll see about the gingiva, which we saw in this case was recession. So what is this recession? What is clinical attachment loss is a term most commonly used in periodontitis. So here is your CEJ, here is your recession. Your recession is from your cement to enamel junction to your gingival margin, right? That is recession. Now your recession plus your pocket depth or your sulcus depth is how much your gingiva has lost attachment from the tooth structure. That is going to be known as your clinical attachment loss. So in this you will see your pocket depth, which is 1 millimeter, plus all this, your recession, that is going to be your 6 millimeter. So your clinical attachment loss is 6 millimeter in this case. So we have identified how to measure pockets, how to check for clinical attachment loss. Now we'll see something else, which is furcation. Now furcation is measured basically with the help of a neighbor's probe, not your Miller's probe, not your Williams probe, but your neighbor's probe. If that's not present, you could use an explorer. So your grade 1 furcation is basically when there's no loss of bone, there's no bone loss as such, there's going to be an incipient lesion. Your grade 2 is something known as cul-de-sac. We keep saying cul-de-sac. Cul-de-sac is basically, this is your furcation. One side has bone loss. It's a tunnel. It's a tunnel which is closed on the other end. That is the meaning of a cul-de-sac. You go through one end, but you cannot come out of the other end. When you can come out of the other end, that is through and through, that is known as your grade 3 furcation. So this is your grade 3 furcation. And along with that, when there's complete loss of attachment, there's complete recession, you can clearly see the furcation. That is your grade 4 furcation. Treatment plans vary according to this, but you need to identify this in the first place. Furcation involvement is an important thing to be identified. Okay, next thing what we check is mobility. So we have checked pockets, we've checked bone loss, we've checked for clinical attachment loss, we checked for furcation. Now we check for mobility. Mobility, you move it according to the Miller's thing. You check if it's grade 1, 2, 3. But if it's mobile, you just don't advise the patient ki extract karo and implant betao. That's not the thing we do. We check for the grade. We check for fremitus, which is something to check for trauma from occlusion. If that's all fine, then we just go ahead and do a splinting. A splinting is only done when there's a functional requirement as such. Like this is splinting. These teeth were grade 1 mobile. When we checked, there was no trauma from occlusion which was present. If there's trauma from occlusion in the anteriors, which we check via fremitus, we are going to do a cornoplasty. Some sort of occlusal adjustment is supposed to be done. Now in this case, this is same like the anterior's law. This area, these teeth which are stable, their area has to be more than the teeth which are mobile, uska area. If it's fine, then we go ahead and take a wire or a splint material, that is a fiber splint which is ribboned. All these materials are easily available. Or your ligature wire splint, you just roll it across and you attach it on the tooth surface with your help of your composite. You etch the tooth surface, wash, bond and attach this. So your teeth are going to be mobile. Many patients come with a chief complaint, your lower teeth are mobile. So this is one treatment which you can do. But when you do this treatment, you should also be aware that the patient maintains their oral hygiene. Because in these cases, if the patient does not maintain their oral hygiene, there's going to be a lot of plaque and calculus accumulation here, because this is a foreign object which is there. A lot of plaque, calculus accumulation, further recession, further clinical attachment loss, and this will worsen this condition. So you have to check patients who are going to motivate. If their patients are motivated to maintain their oral hygiene, you can go ahead and splint it. Otherwise, it's of no use. Now we check for mobility. All the things finally come down to this most important thing, what we all think perio is about, and it is mostly about this, is scaling and root planing. You can see this, the amount of inflammation what is there here. Once we do a thorough scaling and root planing, half the battle is won. Once this is done, you can see this. It's nice and healthy. Okay, there's some sort of inflammation remaining which will progress and go in a few days. So if there's any subgingival calculus, we are going to do subgingival scaling, which we can use with the help of curettes. They are specialized instruments. Now we have scaler tips which are more thinner also, which go beneath the gingiva, or we can use curettes. So this is scaling and root planing. First and foremost step whenever a patient comes to you. Now, this is something which is known as local drug delivery. We've done our scaling and root planing. You see that there were pockets. You measured the pockets with the help of a periodontal probe. Okay? You saw that there were many pockets present. But when we do our scaling and root planing, there are 90% chances your pockets disappear if there are shallow pockets. So when these pockets disappear, you will do a re-evaluation. When you re-evaluate, as in after your scaling, you will check again for pockets. If the pockets have disappeared, in many of the cases, and there are only 1-2 sites where our pockets are present, with only 5 to 6 mm pockets, you don't need to go for a periodontal flap surgery, which we all know, like 5 mm pocket hai, we say periodontal flap surgery, but it's only in isolated areas. So in that cases, instead of going for a surgical treatment procedure, which patients are also not willing to, we can go for something which is known as local drug delivery. This is very commercially available, just for 300 rupees. This is tetracycline fibers, which we insert into the pocket. Local drug delivery, as in locally to the site of action, locally into the pocket. Instead of giving an antibiotic which is systemically affecting it, we put this at the site. The minimum inhibitory concentration at the site is going to be high. We're going to have better results when we do this, rather than going ahead and doing an isolated pocket flap surgery. Definitely, if the pockets are more in number, if it's generalized, we do not go for this. So this is a new treatment procedure which can be done by many general practitioners also. As we spoke about scaling and root planing being the most important, we will see this case, which was a case of drug-induced gingival enlargement. She had come to us. She was an amlodipine, hypertensive patient, was an amlodipine. But along with these local inflammatory factors, which were exacerbating the condition. So you could see how severely enlarged this was. She was an nifedipine here. So this is what it was. And then we did a scaling, a proper thorough scaling and root planing, along with substitution of the drug definitely. And this is how, just after scaling, her condition improved so better. You could see how inflamed it was and how much better this condition is. So that is how important a thorough scaling and root planing is. You just don't do this proper supragingival scaling. You need to do a proper subgingival scaling as well. Definitely in this case, it was a bit difficult to perform subgingival scaling. Took a lot of efforts, but the results, without going for a surgery, you would see this, you would call a periodontist gingivectomy. But no, only with the scaling and root planing, very well managed. Yeah. So this is all what we do for biofilm control. That is your plaque, which is a biofilm, your supragingival scaling, your subgingival scaling, because your subgingival calculus is what contributes to the bone loss. Along with this, you go ahead and you tell the patients, you have to motivate them to brush twice daily in a proper toothbrushing manner. Use of mouthwash only in cases where it is necessary, and never before you have removed the calculus and plaque. Because no antibiotic, no agent is going to act on your biofilm. It's going to cause resistance. So that is a mistake we do. We always have to remove your biofilm, remove the plaque and calculus, and only then prescribe these agents. So this, and not for a longer duration, 14 days. Of course, chlorhexidine, when you give the ADS version, you give for a longer duration. Then You have your toothbrushes with patients who are now wanting to do all this. Interdental aids, very necessary. Each and every patient should be prescribed an interdental aid, regardless of what it is. You are supposed to floss. You are supposed to use an interdental brush. Okay. Now coming to conditions wherein a general practitioner, when they see these patients, they are supposed to refer these patients to a periodontist for better understanding of the case. These are certain general factors wherein they are supposed to refer, and we have certain specific periodontal conditions, like if there is gingival hyperplasia, if there is some resective surgery, if you know that there is a periodontal plastic surgery which is required, that is your recession, your root coverage procedures, all implants, all these cases, it's preferable that you refer the patient to a periodontist. Okay. Coming to indications for periodontal surgery, as we saw already, we could avoid periodontal surgery in so many cases if we do a proper, thorough scaling and root planing. And for normal pockets, shallow pockets, we could go ahead and do a local drug delivery. But like this cases, if after your scaling and root planing, never before, after your scaling and root planing, if you re-evaluate your pockets and you see that it is more than 5 mm, after your phase 1 therapy, that is important, you go ahead and plan for a surgery. Okay, this case again, you will take an x-ray. Never plan it without all these basic things. You go for a IOP. Okay, so this case we'll go for a periodontal flap surgery, as we know. When you see the pocket depths, you can see the pocket depth, how deep it is. There's only 5 markings outside, and this was a periodontal UNC 15 probe, so 15 markings. So 10 mm deep pocket. Definitely you have to go for a periodontal surgery. This is how a periodontal flap surgery is carried out. You open, reflect, all this granulation tissue was the causative was all debrided. You can see how cleanly it's debrided. Presence of subgingival calculus, which is going to be present, which is the causative factor, which further causes issues. So all that is nicely debrided, and then you suture this thing back. Definitely, in patients of bone defects, there is an indication for surgery. You can see this is the defect. I'll show you a case. Now you can see this case. 10 mm pocket. Taken IOPA, you saw this in the X-ray. Now this, what is this kind of defect? It's an angular defect. As you can see, it's angular. Now we've realized that this tooth, this root, this bone loss has gone nearly till the apical third, as good as apical third. Possible chances of endodontic involvement. We go ahead, when you know there's a chance of endodontic involvement, we go ahead and do a vitality test. If the tooth is non-vital, we go and advise an root canal treatment. So in this case, it's an endodontic treatment has been done. We wait for 3 months after the endodontic treatment so that the entire bone is healed around that area. As you can see, the bone level was apically. It has increased quite a bit. So after 3 months, you go ahead and you plan your periodontal surgery. So this is how the surgery was done in this case. We reflected a flap, minimal reflection of only this area. Again, this area was debrided because of the presence of all these agents here. Cleanly debrided, a nice defect which you can see. So this is known as a defect. We probe that defect. So it's going up to 10 mm into this defect. So what we do is we put bone graft. We put bone graft and we put something which is known as a periodontal membrane. This membrane is basically a barrier membrane. Barrier to what? We're going to put the flap back, right? So it's a barrier to the gingival cells of the epithelium. Instead of those cells, we are trying to prevent those cells to come and form and irritate the bone area. You want the bone graft and the bone cells and the PDL cells itself to form bone. We don't want this barrier. We want this barrier to stop the epithelial migration of the cells of the gingiva. So we put this, we put the bone graft, we put the membrane, and we suture it up nicely. And you check. After 6 months, this was the IOPA. So this angular defect which we saw earlier is now healed. You can see this amount of bone which is formed. So this is what we can do with the help of perio. You would say this is a poor prognosis tooth, go for extraction. But you could see how well this prognosis and how well the tooth has survived. Another thing which general practitioners we all do basically is going to be something which is known as crown lengthening. You see a crown You see, you do a root canal. The crown is small, no sufficient height to place a crown. We ask for a crown lengthening procedure. So a crown, as you can see in this case, the crown level length has increased, but we need certain factors to be sure in this case. Okay. So what is something that is known as biological width? This biological width is a concept wherein we see this epithelial attachment and the connective tissue ka addition coming up to approximately 2.04. So when we place the new crown from that level to the bone level, Ingber et al., this guy said that there has to be 3 mm from the crown which you're going to place. So your restorative margin which you're going to place, your new crown, to your bone level should be at least 3 mm. That is biological width 2 mm plus 1 mm for sulcus, he says. So he says it has to be maintained. But what if you don't maintain it? Suppose you place a crown and it's very close to your bone level, 2 mm se kam hai. So two things can happen when your biological width is violated. Okay, when your tissue is thin, your gingival biotype is thin, as in patla thoda gingiva, that's going to cause bone loss and recession in that case. Because the bone goes to a level, it has to go to a level of 3 mm. So when you place it 2 mm pe, bone would recede. There's going to be bone loss. So your gingival biotype is thick, we're going to have inflammation in that case. So again, the bone and the gingiva would try to maintain itself at a 3 mm level. So this is what happens if you don't maintain the biological width. So crown lengthening is an easy procedure, but certain factors have to be taken into consideration, which is your biological width has to be maintained. So in this procedure, we do a crown lengthening. We take this gingiva, we remove it, excise it, we raise the flap. We raise the flap because from the newer margin of gingiva to the bone, it has to be 2.04. So approximately 3 mm. So we reduce this bone. We reduce this bone so that from this to that level, it is 3 mm. And then we go ahead and place your crown. So now you can see in this, the gingiva is nice and healthy. There's no issue after placing the crown because the margin and the bone level would be at a proper margin level. Another form, see in this case also, you could see that there is crown lengthening required because the teeth are so small. We needed a crown lengthening to be done in this teeth. But when I saw this case, I saw the gingival biotype seems very thin. Also, what we learned earlier, attached gingiva, which was from the mucogingival junction. So this was the mucogingival junction. So when we saw the mucogingival junction and we wanted to increase this crown height, we would have to cut aisa, jaise we cut in the previous case. That would reduce this attached gingiva further on. This was mucogingival. We would do a cut like this. When we would do a cut like this, my attached gingiva would reduce tremendously. And we had certain people like Lang and Lowe in 1972 and Friedman et al. Who said that we need attached gingiva. 1 millimeter is necessary to at least maintain the health of the gingiva. Because if there's an inadequate zone of attached gingiva, we could facilitate plaque formation. Hence, in this case, I thought if we need to go for a crown lengthening procedure, we cannot just go ahead and cut the gingiva. So what we did in this case was something which is known as an apically displaced flap. You must have heard of apically displaced flap to increase the width of keratinized tissue. That is the thing what we did. So we gave vertical incisions, we raised the flap, a partial thickness flap lower down, which is leaving the periosteum. We went right up to the movable tissue, that is the alveolar mucosa. When we go right up till there, we can move the flap till wherever position we want. So we took it and we apically displaced it. This is without cutting any gingiva. We have achieved increase in the crown height and nice width band of attached gingiva which is present. You can see till this level. So we got a nice healthy band of attached gingiva. So this is apically displaced flap. So we need to see in these cases when we ask the people to do crown lengthening, you all can do crown lengthening, but be certain that we are not compromising on the width of attached gingiva, which is a very important factor. So this was finally how it worked. This was the post-operative view. Can you all see? This is the crowns which were placed on the teeth. Another cases which come and which should be done are a high frenal attachment case. You can see this frenal attachment causing diastema. Even if you do your orthodontic treatment, this thing is going to apply pressure, and never apply this thing to get closed. So we do a frenectomy, which is this way. We use a hemostat, cut off the frenum suture, and that is what we end up doing. Another procedure which we do is when a patient comes to you not happy, not satisfied because of this pigmentation, we go ahead and do a depigmentation procedure done by many techniques with a scalpel, with a burr. Like in this case, we've used a burr and we've achieved a nice pale pink gingiva. A patient has to be told, but in certain cases, that this could reoccur. Definitely not in such a thick band, but those melanocytes could form melanin, okay, but not such a thick band. But after approximately 6 months or so, there are chances of recurrence. That has to be told to the patient. This is a case of operculectomy. Your crown is not visible. Very easy procedure which can be done. Cut it off. Opening of your thing, because it's a problem. It can cause a pericoronitis in this area, inflammation of this tissue because of food lodgement. The next case. Now this is something which is there, which is very common, which is commonly seen. Something which is a periodontal abscess and a periapical abscess. Now a periapical abscess is going to be related to endo. You have going to have a carious tooth in this case. You can see that this is found apically. There is no pocket. What we saw pocket, we'll probe and we will see. When we probe, if it goes more than 5 mm in certain area, we would say it's a pocket. So in this case, if we would probe, we would not find a pocket. But in your periodontal abscess, if you probe the region, you would get something which is this. That would be a pocket which was involved in the periodontal abscess. In this case, in your periodontal abscess, your tooth would be vital. In your periapical abscess, your tooth would be non-vital. Let's see a case of periodontal abscess. So this is the periodontal abscess and this is the 1 month follow-up. So how did we treat this case? This was the abscess. We saw the probing depth, deep pocket. You can see this area, these things. This is subgingival calculus which is present. Etiological factors of all of this. We do a curettage. We go ahead and do a flap if this doesn't suffice. We did a flap in this case. Then we check the probing depth. It's decreased. And this was the post-op X-ray. So this is how we have to treat abscesses. The free gingival graft. Now we saw clinical attachment loss. We saw recession. So this was a case of recession. In case of recession, where the patient wants, it's not happy, we go ahead and do a free gingival graft. Now what is this free gingival graft? It is something which is taken from the palate. We do this procedure by taking this gingival portion from the palate. This is the palate, where this is the template which we actually create. Ki how much of gingiva do we need? This is the connective tissue bed. So that what we place, the epithelium what we place, it has to get accepted. Epithelium pe epithelium if we place, nothing is going to get accepted. So we de-epithelize this vascular bed. Take epithelium from the palate, epithelium plus connective tissue from the palate, attach it on this portion, suture it up, and this is how it is going to be done. So you can see this. Because it is from the palate, it's going to be a slightly different color. That is the disadvantage of your free gingival graft. A slight different color, this triangle which you can clearly see what we are taking. But nevertheless, recession has been covered. There's another case also wherein patients want this black triangle which you can see. This is the cases of black triangle. So you can manage it non-surgically. We tried managing non-surgically, not possible. We go ahead for a surgical procedure. This is modified Beagle's technique. Partial thickness, place it here, suture it up, and we get a nice closure of your interdental papilla. So all these procedures can be done by periodontists. So we'll conclude our presentation saying, of course, as we saw, periodontal diagnosis is of utmost importance. So once you diagnose the case, you need to diagnose, and the treatment should be incorporated by the general practitioner into their practice. You try your gingivitis case, you do a proper scaling, a proper supragingival and a subgingival scaling. You realize there's still subgingival calculus present, the condition after re-evaluating, you realize the pockets are still present. You refer the patient to a periodontist to further carry on the procedure. Okay, and we have to try. Okay, it is imperative, as it said, that non-surgical therapy should be understood, like scaling, root planing, re-evaluation, maintenance phase. All these things should be understood, and only then we can avoid the surgical procedures. And as we said, maintenance is important. The patient has to be motivated to maintain his oral hygiene. Once you do a flap surgery, once you do any treatment procedure, the patient has to be motivated that he maintains his plaque and calculus levels, and only then will there be a proper long-term satisfactory level. Okay, this is what it's all about, your periodontics for your general practitioners. That's how I'd like to conclude. These are my references. Thank you.
Thank you, ma'am. That was the whole brief presentation, like recalling final year.
Yes.
It was like, I'll just check it if we have any questions. There are no as such questions like put up in the chat box, because the whole presentation was so brief. So, like, it is simple and sweet. Like, everything is concluded with that.
Thank you.
Thank you for your time. And also, I like to conclude today's webinar by announcing that as a Mediush member, I would love to announce that we are further going to arrange the various workshops, such as rubber dam workshop, rotary endodontics, fixed orthodontic workshop, and full mouth rehabilitation workshop. Also, for all the cricket lovers out there, we are also arranging Mediush Premier League. So whoever were hoping to see you all there.
It's very lovely. I thank Medius to give me this opportunity to present this. Thank you so much.
Thank you, ma'am, for your valuable time.
Thank you.